Sollis. Better insights for better outcomes. This session was recorded live at our Advances in Population Health Management workshop in London, November 2018.
It now gives me great pleasure to invite to the podium a very good friend of mine, Dr. Steve Laettner.
Okay, hi everybody, good morning, welcome, and thank you to Nigel and the Sollis team for inviting me to talk to you today. It's a great privilege to do so. I'll run through the slides very reasonably quickly to give a chance for some questions and reflections at the end of the talk, but we'll have a bit longer later in the morning for more in-depth discussion. This is a very personal view of population health management that I'm going to give you. It's not the Sollis view, it's certainly not the NHS England view or Public Health England view, it's just my own personal view of population health management. So the clue's in the title really. It is about managing the health of the population, and Nigel's given us some great reminders of the burning platforms in terms of health inequalities, but also lots of unmet need and dare I say quite a lot of instances of oversupply of healthcare, giving people more than they either need or want. So we've not aligned properly the needs and wishes of the population with the delivery of health and care, and I think that's what population health management is about, is to try and align those things. I am on Twitter at Steve Laettner, so please do tweet away, and this is just my own view of the world. It's not necessarily correct. My enthusiasm does sometimes make people think that I think I know it all and I don't, and I've got a wife and 3 teenage daughters at home who remind me that often I'm not right. So please do challenge and comment either on Twitter or in the questions afterwards. So why me? I'm sure you're all asking. And why am I in this space? Well, interestingly, I've come from 2 career backgrounds. I'm a part-time salaried GP in St Albans in Hertfordshire and really enjoy doing that. I'm also a public health doctor by background. I've trained as a public health consultant as well. The first time I applied to be a public health consultant or join the training scheme, I didn't get on it. I wasn't successful because they thought I was too interested in general practice. So I applied the year later and kept stum about my interest in general practice, and I've had a dual career of general practice and public health. And I think I finally find my home in population health management, which is bringing those 2 worlds together. And they're not in conflict. And as my old boss, Sir Muir Gray, says, individual health and public health or population health are 2 sides of the same coin. So I'm very comfortable working in that space now and enjoying working with Sollis some of the time, with other consultancy companies, and very much with the NAPC, National Association of Primary Care Home programme. And it's great that Annabelle and Jag from NAPC can join us today. And we are doing some great work with primary care homes across the country. Jag and Annabelle particularly in Dorset, but we're in lots of other areas, and I think we're beginning to make population health management a reality, and I think it's working partly because we've got the size right. So unusually, people from different organisations seem to agree that there's something about a population of 30 to 50,000 that makes sense to the people who live there and to the people delivering care. So I think population health management has got its day, and it's found its home, its playground in local communities of 30 to 50,000. The patient customer, I say this because this is the best quote I've seen from Steve Jobs about starting with the customer experience, the needs of the patient, the individual, the client, whatever you might want to call the patient first, and then thinking about how we provide solutions to them. And I think it's a great quote, and Steve Jobs, as we know, went further to anticipate that people would really like an iPad before they realised it's what they would want. Just like in my practice, patients probably didn't realise all the things they could discuss about their health needs on the phone with a doctor and assume that we'd need to see them, but actually when they're experiencing remote consultation, actually they quite like it. So start with the patient, the population, the community. Don't do this, which is a bit of a tendency of the NHS, is to look through the lens of the professional, the organisation, general practice, hospital, trust. It's understandable. It's human nature to think from our own perspective first, and that's why we need patient leaders and working with communities and patients, because only they see the world primarily through the lens of the patient and user and the population, which enables us to take this sequence. We're starting, and this is what population health management and Sollis and others can help us with. Let's really understand the needs of the population. Let's understand where to focus initially, because we can't do everything at once. And then let's think about, for example, the exam question in the Western world, frail elderly or older people with complex needs. It might be children with complex needs, it might be other groups. But let's start with a focus. Let's think about what functions we need across health and care sector, but also assets in the community to meet the needs of that population. And then we think about funding, and then we might need to think about organisational form. I do believe NHS England does have a tendency, or did have a tendency, to think about organisational form first before the other things, and that's not the right way round. So population health management helps us to do that. I've started also doing a bit of work, again with my old boss Mia Gray, on triple value healthcare, and they've got a really neat concept where they think about value, outcomes over cost, from the perspective of the population, the individual within the population, and the people who are providing care and support to that population. And that would include NHS providers of healthcare, but organisations like Sollis who are providing services to that population, or pharmaceutical companies or whoever. And ideally, we want to be hitting the P spot in the middle, which is where we're aligning the values of the individual. So we're delivering care that is highly valued by the individual. It's worth them taking time out of their work and their family time to have that intervention or that support. We're improving the health of the population given the resources that that population has, and we're delivering things in a very valuable way for the providers. I suppose this is where the sort of technical efficiency would come in under the provider space, and we need our job, I think, is to make those circles more congruent. So we need to think about the customer, the client, the community, particularly at the 30,000-50,000 level, and we need to think about value from different perspectives. I won't go in detail on these definitions, but just to say, I think public health and population health is about interventions across the whole population. Population health management is when we get into understanding the segmented needs, the cohorts within a population, and how we manage different groups differently. Because funnily enough, different cohorts, different groups of people with similar needs need different types of support. I'm not so sure, I'm not a big fan of the word impactability, partly because I'm not sure it's a word, but also because for me population health management, although we might be starting with a priority area of focus, it's about improving the health of the whole population. But as the saying goes, eating an elephant in chunks, we're doing it one big chunk, one segment at a time. So I think actually the whole population is impactable. Every cohort is impactable, but we might start somewhere. One of the things I get challenged on is that, and it'd be great to hear from Jeremy Taylor from National Voices later today. Some people say to me, but segmentation is not in keeping with personalisation. My own view is if we get it right, it will aid personalisation. And I think there's 3 stages of personalisation. We personalise care to the community, to St Albans where I live, or to Lewis, one of our primary care homes, or to Central Bedfordshire where I was yesterday. There's something about personalising care, understanding the needs of that community. Then there's cohorts of people within the community with similar needs. So that's another step of personalisation. And then we personalise for every unique human being within that cohort with their own needs, values, preferences, goals, etc. So in no way are we forgetting that every individual is unique, but people who have multiple comorbidities, physical health problems, mental health problems, dementia, disability towards the end of life, there is something similar about that cohort, and they will share similar needs, and you can do that whilst recognising the uniqueness of every individual. How we segment is really important. So I'm dead against segmenting by disease. That's not to say we're not interested in what conditions and diseases people have, but that's not the first cut. We're not defined by the diseases or conditions we have. Nor are we defined by our risk of being admitted to hospital, although that will also be important to know. But what we try and do is define the holistic needs of individuals and groups of individuals. And the way myself and my long friend Mark Davies, not that he's long, but we've been friends for a long time. Sorry, that fell a bit flat. So, excuse my odd sense of humour. So what we decided, and this took a lot of thought, so not to quote Shakespeare, but to quote Mark Twain, the comment of, or the quote of, "I didn't have time to write a short letter, so I've written a long one." This is the opposite of that. Mark and I, being sad creatures that we are, have had decades to think about this, and the earlier models I came up with were very, very detailed and complex, so we've had decades to perfect something as simple as this, which is a 3x3 grid, and it's basically saying there's 3 big life courses. There's children and young people up to the age of about 25. There's lots of evidence that the brain matures more by about 25, as you've heard from my jokes this morning. Mine's going to take a little bit longer for that, but there's children and young people up to about 25. There's working age adults up to maybe 65, 70, wherever retirement age is. These are sort of slightly loose boundaries in thinking, although we need to define numerically the boundaries in any area we're working with. And then older people. But clearly that's not enough. The variation in needs in each age group is major. So then we need to think about people who are generally well. There's no identified long-term condition or long-term need, physical, psychological or social. People are getting on okay. There's also people with long-term conditions. So they have an identified need, or it could be a social need, whatever sort of need they have, which needs some sort of ongoing care and support. And then there's people who have complex needs, and by that I tend to think of not just physical comorbidities, but a mixture of physical conditions, mental health problems, social need. So in the children and young people, it might be children who have learning disability and autism and some social needs, maybe physical disability. Working age adults, there's a cluster in there which is quite predominant of people who have mental health problems, drug and alcohol problems, social problems, maybe involvement with the criminal justice system. And then for older people, it tends to be the clustering of, as I've said, physical comorbidities, mental health problems, social isolation, end of life, dementia, etc. Then we might apply some risk profiling to those cohorts. So we talk about segmenting first and then risk stratifying. I have arguments with my friend and colleague Rupert Dunbar-Rees from Outcome-Based Healthcare about who thought of that first. So we decided we probably both thought of it about the same time. So we segment by holistic need and then we risk stratify. We don't just risk stratify people. And then we might also think about what conditions people have within the cohorts. But there's a logical sequence: start high level and then get down into greater granularity. We've then developed, through NAPC, working in primary care homes, particularly in Bedford, Luton and Milton Keynes. We're working with that ICS. We've developed some criteria using System 1 GP system to actually populate the matrix, to light up that grid with people. So we've come up with some risk factor definitions that are slightly different in children and the other cohorts. We've looked at the different long-term conditions that are coded in GP systems. We've identified people who are high risk because of multiple comorbidities or single comorbidities and risk factors. And then we've thought about the sorts of reasons that we'd put somebody in the complex groups. And the reason for doing that is the needs of those different groups are different. And we have a scarce resource in terms of integrated care. So as I don't work for NHS England or the King's Fund or anyone else exclusively, I'm allowed to criticise. And I think what some organisations and think tanks have done is they've almost suggested that everybody needs integrated care. But of course it's more nuanced than that. Some people towards the left-hand side who are generally well, the sort of people who are on my triage list on Tuesday, who are a perfectly well person who has a urine infection or an upper respiratory tract infection or have got a sprained ankle, and I tend to direct them to minor injuries, but the sort of acute episodic illnesses for people who don't have any complex needs, they don't need integrated care and they don't need high degrees of continuity. But boy, do these people need those things. So let's not treat everybody the same. Let's find those groups in the population who really need a multidisciplinary team wrapped around them with high degrees of continuity. So we've lit up the matrix reassuringly, and this often comes as a surprise to my GP colleagues because when you work in a practice it doesn't feel like it. Almost 3/4 of the population are well. Wow. About a quarter of the population, though, have some sort of long-term condition, and between 3 and 5% will have complex needs. We can delve more into that, but that's helpful, and people really get it. Whether you're a citizen, a manager, or a provider of healthcare, it makes sense because it's simple. We then apply a third dimension, which was Mark Davies's idea, of each of those cohorts. Each group will have prevention needs. How do we prevent them moving from the left of the matrix to the right? The last two columns, people with long-term conditions and complex needs, will have some ongoing care needs to manage their long-term conditions or long-term needs, and every cohort will have, and we're happy to make all these slides available, aren't we, Nigel? Yes, we are. We are happy to do that. And every cohort will have urgent care needs, but the way we respond to the urgent care needs is different depending on what cohort people are from. One of our great primary care homes in Lewes, which is a lovely town in Sussex, which I'd never been to, but is very pretty. And they've got a great clinical lead there called Phil Wallach, who took my population grid, mine and Mark's grid, and used it. And plagiarism is the greatest compliment, so I was delighted that he took the grid and used it. And what they've done is they've applied different teams or micro teams or teamlets, whatever we call it, within the primary care team that are focusing on the different cohorts. It takes quite a bit. I was with a practice partnership in Watford for 5 hours the other week. It takes about that to realign clinicians from their wrong end of the telescope view, it's all about doctors and the practice, or the disease view, to this segmented customer need view that most other industries would be very familiar with, but people working in healthcare being who they are, that takes a bit of realignment, but it's critical. So then the team for the far left, that's about the acute care needs of people who are generally well, and it's about prevention. The middle group is about disease management, but also the acute care team might manage their needs if it's quite straightforward, or you might need more continuity. And the people with complex needs, only about 3 or 5% of the population need something very different. So they need, with this diagram, which I won't go through all of it, but it's basically saying, if you're somebody who's generally well and you've got an acute care need, it really doesn't matter which clinician calls you back and who sees you. But actually, if you're in the group in the middle, and both those two columns is about reactive care, actually you need a particular person to ring you back. It might be a clinician, or it might be somebody else who knows you well. And then you need, if you're going to be seen, probably seen by somebody who knows you really well as well. So when I was on triage on Tuesday, it works really well when I speak to people I don't know, or I might know them, but they don't need continuity, and things are sorted on the phone or they come in. But if I'm speaking to somebody with very, very complex needs, it's very difficult, and it's much better for somebody else to be speaking to them who knows them really well. And we haven't got that right yet, but I think Lewis has got that right, because as far as I understand it, when a patient calls the surgery, there's a coloured label which says which cohort they're from, And then, most importantly, because everyone's a unique human being and their needs from time to time will vary, the call handler has a conversation with them about which team is most suitable to deal with their call at that time. So I've built up to a bit of detail there, and then the team on the far side, that's about the small 3 or 5% which need very proactive as well as reactive care by a multidisciplinary dream team. So I've downloaded all my thinking to you. As I say, I'm very enthusiastic about it all, but I'm not in any way suggesting that this is all right, and I'd be really delighted to take any comments or questions or reflections from you. Thank you.
Could we thank Steve in the usual way?
For more information and insights, visit our website, sollis.co.uk.